Thank you very much. I'm kind of feeling sorry for myself at this point. It's Friday afternoon. It's after lunch. It's after a break. I'm after Dr. Firetag. I think I'm diagnosed with a stage 4 audience. But you know what? Being the last speaker, I think I can handle it. I'm a gastroenterologist, and I'm often called to come from behind. So, okay. Well, I'll tell you what. Let me just make sure I've got everything I need. Okay. It's my task today to talk with you, just kind of give you a little bit of an exposure to EUS and GI oncology in 2018. I'm going to talk a little bit about diagnostic EUS. I'm going to talk about cancers of the esophagus, the stomach, the rectum, and the pancreas and biliary tree. And then I'm going to talk a little bit about therapeutic and advanced diagnostic EUS. I'm going to talk about CELIAC, PLEXUS, NEUROLYSIS. We'll see how it goes. I'm going to probably talk about an endoscopic, well, we will talk about endoscopic gastrojejunostomy, radiofrequency ablation of pancreatic neuroendocrine tumors, fiducial placements. They're little metal probes that you can place into a tumor to help localize this, to help guide therapy. And we'll maybe talk about intratumoral therapy. Well, EUS in the basics basically is nothing more than a diagnostic supercharged endoscopic procedure. The preparation for EUS is similar to an upper GI endoscopy, or if we're doing rectal, it's similar to a sigmoidoscopy. We use MAC and propofol, a little bit heavier sedation, because there's studies that show that the results are a little bit better if the patients are, if the movement is a little bit less. This is a really accurate and precise type of procedure. The safety profile, you should know, is very good. There's a 1% or less rate of hemorrhage, and if you biopsy the pancreas, it's still 1% or less chance of causing pancreatitis. This is the scope. I use a linear scope. There's also a radial scope. This is a little bit harder to learn, but it allows you to biopsy at the same time. So the scope is here. You've got an ultrasound transducer at the tip, which allows you to look at the wall, through the wall of the organ, be it the stomach, esophagus, etc. And you can see outside into the adjacent organs. And then you have a channel that you're able to put the needle through that will then biopsy the mass lesion. Now, the secret to EUS is basically getting the scope in close proximity to the area that you want to examine. So when you place a scope through the esophagus, you can see the mediastinum, you can see lymph nodes, and then as you go through, there's various stations. But here, if you're up high here on the lesser curvature of the stomach, you can see the left lobe of the liver, and you can look backwards, you can see the aorta, the celiac artery, and the SMA here. As you go down, you start to see the pancreas. You can see, as you look backwards, you see the pancreas, backwards you look and you see the pancreas on the greater curve, I'm sorry, and you see the tail. You move toward the body and then the neck. From the antrum here, you can look up and see the gallbladder, and then when you move the scope into the duodenal bulb, that's really the workhorse view. The bile duct is right behind you as it enters into the pancreas, so you've got the bile duct. You get up into the hilum here. It's a little bit difficult, but you can do that. You can see the head of the pancreas. As you put the scope down, you can see the right lobe of the liver. This is called the pullback view. As you come into play, you can look at the ampulla, and the pancreatic duct and the bile duct are entering into the ampulla, and you really are able to get magnificent views if you can place the scope in the right spot. The real gold in EUS to date has been biopsy, and we can either aspirate or take biopsies. And here you see again the needle going into a mass lesion. We use on-site cytology here at SLO. That means that the cytologist, which is often Brandy Firetag, is in the room with me as I take the biopsies. We interchange. This is really the secret to high yield, is we interchange whether we have the diagnosis, whether I'm in the right area, whether I got to go to another area, whether, sometimes I'm going through vessels and I'm getting anxious. And Brandy says, okay, you don't need another biopsy. I think we're okay. And I will say, by the way, Brandy did come here a couple of years ago from UCSF, and it's been a real pleasure. We spent a lot of time together. She is a very talented lady. Okay. Now, EUS, the role of EUS in the tumors of the esophagus, stomach, and the rectum is primarily for staging. You get T staging is the depth of penetration. The lesions start on the mucosa and they work their way down. And the beauty of EUS is there's 5 layers that alternate between a whitish, or what we call hyperechoic, then dark, light, and these correlate with the lining, the wall. Here, the first layer is the superficial mucosa. The second layer is the muscularis mucosa, submucosa. Then the fourth layer is this dark area. This is the muscularis propria, and then the adventitia, or the serosa. And so what we do is we will look and see how deep the tumor is penetrating, and that helps us to give us a T stage and helps us to tell us what the appropriate therapy might be. In addition, we'll also look for lymph nodes. Now, with esophageal cancer, the first thing and the first concept with really all the luminal cancers is that the first test you're going to do after you make a diagnosis of esophageal cancer is you're going to do a CT scan. You're going to look for metastatic disease. If you don't have metastatic disease, then you want to be thinking about an endoscopic ultrasound because you want to see how deep the lesion penetrates. If it just hits the mucosa, that's a T1A, you can actually remove those lesions. We remove those with endoscopic mucosal resection. Don't really need an esophagectomy. As it goes into the submucosa, the risk of lymph node exposure enhances, and we tend to go for an esophagectomy. And then as it goes deeper into the muscularis propria, that's T2, you might be thinking neoadjuvant chemotherapy, and T3, you're going to be thinking more about chemotherapy. But also, with EUS, you might find ascites or liver mets that are not seen on cross-sectional imaging, and that makes the patient stage 4. And with stage 4, they really don't need an esophagectomy. The other thing we do is we look for lymph nodes because at times I'll identify lymph nodes that are high cervical when the tumor's down in the GE junction, and that'll alter the radiation field. Just a quickie, and I'm not going to go through these slides very deeply, but basically, EUS is probably the way to go on T staging for esophagus, 80 to 85%. For T stage, and for lymph nodes, 75 to 85. So it actually does very well when compared with CT and PET scan for certainly for T staging and also for regional nodes. Now, there are 4 criterion that we look at when we're doing an endoscopic ultrasound to determine whether a lymph node's malignant. They can be round, smooth, hypoechoic, which is dark, and they are greater than 10 millimeters, but only about 20% of lymph nodes will have all 4 of those criterion when they're malignant. So we like to stick needles in these nodes to define with certainty whether or not they are indeed malignant. The staging is about 75% off shape and configuration, but you move it up to 95% accuracy when you biopsy, so you can see the value there. And I'm just going to show you a couple pictures here, but basically, this is a patient that we had. He's an 86-year-old gentleman, maybe he's 87 now, and he has multiple comorbidities. He's got extensive cardiac disease, and he's on anticoagulants. And if you look closely, you're going to have to. This is the first layer, which is the mucosa. This is the deep mucosa, the muscularis mucosa, submucosa, and this is the muscularis propria, and then the white is the adventitia. So I get 5 layers to look at. Okay. Now, in this is his normal, this was his normal, and now this is his tumor. And you can see the tumor here seems to be invading. You don't really see that white anymore. This is a T1B or T1S. This is a lesion into the submucosa. So in a lesion into submucosa, you're going to take surgery as the option, but when we present him in our tumor board, which really is a phenomenal resource, the surgeons just weren't interested. He was just too old, had too many comorbidities. So I actually removed this tumor endoscopically, and on his last examination, he's doing fine. But he still runs the risk of lymph node metastases. Okay, here's another patient I appreciate they're hard to see, but this is that muscularis propria that I was talking about, and you can see that the tumor is invading into the muscularis propria, but the muscularis propria still maintains its integrity. This would be a T2 lesion. Okay, gastric cancer, more the same, okay? And I don't want to get repetitive, but the first thing you do is you get a CT scan, a contrast CT. But if you don't have metastatic disease, then you're again talking about doing an EUS. It is the same kind of thing. T1A, where it's just in the mucosa, we can remove that as gastroenterologists. But as it gets progressively deeper, we need surgery, and we may call on neoadjuvant chemotherapy to help as a prelude. However, there are a couple roles for EUS. Beyond that, often we find ascites or liver metastases. This ascites actually implies that there's peritoneal carcinomatosis. Liver metastases we might see that are not seen. These will make a patient unresectable and will save them a gastrectomy. There's another type of tumor of the stomach called linitis plastica. That's a tumor in which the lining of the stomach is normal, but the tumor tunnels underneath the lining, and those are very hard to diagnose at endoscopy. You might find just a rigid stomach or a lack of motility. So EUS is very helpful in biopsying those lesions as you can get under the lining. Now here's a patient who was actually sent to me from Santa Barbara a couple of weeks ago, and there was a very tiny tumor in the stomach, and they asked me to take a look at the patient and see about resecting this with an endoscopic mucosal resection. And I did an EUS first, and they did ask me to do this. I did the EUS, and you can see this is the muscularis mucosa, and these are called pseudopodia, and it's invading into the submucosa. And this is classic, this pseudopodia. So you can see, as soon as I put the ultrasound probe down, I said, I'm not going to resect this. This is a surgical lesion. And in fact, despite the fact that the patient had a CT and a PET scan, I was able to identify this lymph node. And this is dark, it's hypoechoic, but it's only 5 millimeters. But you can see how well I'm looking at a 5 millimeter lymph node. And we biopsied this, and in addition, there was adenocarcinoma in the lymph node. So this patient was nowhere near a resection, and he actually went to surgery. This is another case. This is that linitis plastica. The lining's normal, but you've got this dramatic expansion. All the layers are ablated. You don't see the 5 layers. All you see is this dark mucosa, and we're easily able to get our needle in here and achieve a positive biopsy. Now, linitis plastica is a very aggressive gastric cancer, and at this point, we're thinking about doing surgery, but as I ran the ultrasound scope up on the liver, you can see this dark band, which is a small amount of ascites. Now, this doesn't really make the diagnosis of peritoneal carcinomatosis, but it certainly suggests it. So when we talked about this at Tumor Board, we recommended either doing a laparoscopy or using neoadjuvant chemotherapy, and she's currently getting neoadjuvant chemotherapy. So we're headed towards surgery, and again, endoscopic ultrasound kind of picks up these findings that guide therapy. Rectal cancer, there's a little competition here between EUS and MRI, but I think I can summarize it. Again, CT of the abdomen, pelvis, and chest, with and without contrast, is the first test. But if you don't have evidence of metastatic disease, you do want to be thinking about EUS. But the concept is that with the T1 and T2 lesions where the tumor is just in the wall, you can go right to surgery. However, if the lesion penetrates the wall, that's T3, those patients are going to get neoadjuvant chemotherapy with chemoradiation. Or if there's a lymph node involvement will push you from a surgical option to a neoadjuvant chemoradiation. Now, MRI does have some advantage. It sees the extent of the tumor much better, and my surgical colleagues are very interested in doing that. They like to see the relationships to the extra rectal organs, what they call the mesorectal fascia, and to the sphincters. But again, EUS has that better T staging so that you can determine whether or not it's T2, T3, and determine whether or not you're looking at chemoradiation. Also, you can sometimes, just as I said, find these lymph nodes, and you take a patient from chemoradiation, from direct surgery, and bring them to chemoradiation. Before I show you a couple pictures, the other indication for EUS that I really appreciate, and I think the oncologists are feeling more comfortable with this, is after you resect the patients with rectal tumors, the anastomosis is vulnerable to recurrence. And if you wait for CT and MRI to show you recurrence, it's down the road. And with EUS, you can see areas right next to the anastomosis, and even if you're not really sure, you can put a needle in it, and a lot of times you come up with malignancy, and you allow the time to diagnosis to decrease and perhaps enhance the outcome. Now, here's a patient that we had. It's just a typical rectal cancer, and you can see, remember we talked about this muscularis propria, it's gone. This is it being in, you see the tumor invading into the adventitia. This is a T3 lesion. This is a case of a patient that will not go to surgery, but will go to chemoradiation. Now, this is a case that we had about a month ago, maybe a little bit longer than that. But this was kind of interesting. This is the tumor right here, this dark band, and you can see that it's, well, you got to take my word for it. It's invading into the muscularis, but a little bit, but it's certainly not through the adventitia. So it's a T2. So it's in the distal rectum, and it looks like a surgical case, and the surgeons were getting ready, and a chance to cut's a chance to cure. And I just learned that about a week ago. And anyway, but I took the scope up to the lower abdomen, to the iliacs. There's a bed of lymph nodes, and we've got this 5.6 millimeter lymph node, and I didn't think it was going to be positive because it's really about 7 inches above the initial tumor, but it was positive for carcinoma. And at that point, since we saved the patient in surgery, they really benefit. Their survival is benefited by chemoradiation. So these are the kind of cases that keep coming up, and that where EUS becomes really pivotal. All right, just going to go through EUS with pancreatic cancer. There is, if we leave here with one thing, well, hopefully leave here with more than one thing, but EUS is the most sensitive test for pancreatic cancer. With all the improvements in cross-sectional imaging, EUS can you're still at the level of 2 centimeters with MRI and CT, and I'm finding tumors down into the range of 3 to 4 millimeters easily. So EUS, the most sensitive for tumors, and as I said, it really shines on the smaller tumors. It's really valuable when the lesions are small, and when they're small, that's your best chance at curing them. So EUS has a major role in pancreatic cancer. I'm going to kind of short the staging, but I did go through this, and the staging with pancreatic cancer is a little different because the T stage and the N stage aren't as important. We kind of lump them into whether the tumor is resectable, whether it's borderline resectable, or whether it's unresectable, and we define the treatment based on that. Now, these are NCCN guidelines from 2017, but I kind of modified them, but I'm going to make it real simple. Resectable means there's no metastatic disease, and there's no major arterial disease. The only thing you can get away with, just so you understand, with pancreatic cancers, we're looking at the celiac artery, the superior mesenteric artery, and the common hepatic artery. And from the venous standpoint, we look at the superior mesenteric vein and the portal vein. The only venous involvement that's acceptable to make a patient resectable is a little bit of irregularity to the portal vein, and I'll show you this in a second. Unresectable is either distant metastases or significant involvement of the arteries, or the venous side where you are involved but you can't resect them. And then finally, borderline resectable, which is this interesting subgroup of patients, because we like to give neoadjuvant chemotherapy to take these patients that are borderline resectable, and we think that by giving them chemotherapy up front, neoadjuvant chemotherapy, we may make it more likely that they have an R0 or a margin-free resection. And there are criteria, and I'm not going to bother you with this, but basically, if you have some SMA, less than 180 degrees on the arteries, or venous involvement that you can hook back together, those are borderline resectable. So, the key points then with EUS and pancreatic cancer are that EUS, again, as I said, is the most sensitive modality, but the best test to start with, again, is a CT, a triple phase contrast CT, which has uninfused. You get an arterial set of windows, and then you go to a portal venous phase. That allows you to see the SMA artery, the superior mesenteric vein better. But the EUS still has a role in those of us that do a lot of it, because I think it's superior at looking at the portal vein. And as Brian was saying, a lot of these cases come down to how much the portal vein is involved or not. EUS also has the ability to confirm or identify hepatic metastases, ascites, or celiac adenopathy, and if it's in the head, that's considered to be non-local regional and would make the patient unresectable. And the other thing that you need to remember is that not all pancreatic masses are adenocarcinoma. There's neuroendocrine tumors, which are can be when they're smaller, something you might be able to follow. There's something called autoimmune pancreatitis that can present as a mass. There's lymphoma and chronic pancreatitis. So the important aspect here is that you probably want to biopsy pancreatic masses. So let's go through a couple of these. This is a case of a gentleman that was referred, he's a 50-year-old gentleman. His father had pancreatic cancer, and he had diverticulitis, and they found a mass in the head of his pancreas. So they sent him up to me, and I didn't find a mass in the head of his pancreas. What I found, this is a very large pancreatic duct, and the pancreatic duct, when it was dilated throughout, and I immediately recognized that this is what's called a main duct intraductal papillary mucinous neoplasm. It's a very precancerous type of condition. But I didn't find a mass. There's no solid mass. What he did have is he had this nodule in the duct. So I went ahead, and I think Jim Hanna, Brandy's counterpart, was with me, and he was getting all nervous. But I went ahead and biopsied this, and it came back mildly dysplastic. Well, the patient lives closer to UCLA, so he elected to go down to UCLA. And the surgeon called me, who was thinking about operating on me. He goes, I'm looking at this CT scan, and it shows that the superior mesenteric vein is invaded. And I go, well, there's just no mass there. So he goes, take another look. So I went back, and I could not find any mass, and I couldn't find any invasion of the superior mesenteric vein. And I went ahead and biopsied this nodule, and this time we got high-grade dysplasia. So he's bordering on cancer. And we ended up, I talked with the surgeon, I convinced him to do a Whipple procedure, and he did, and indeed it was just this. I mean, the ultrasound saw it best. It was just a main duct IPMN with a high-grade dysplastic nodule. Patient had a Whipple procedure, and he's cured. So that's a good thing. Okay, so here's what I was talking about. This is bread and butter anatomy for us. I'm in the duodenal bulb, and I'm looking at the bile duct here. And the way it works is this is the liver. The orientation is liver over here. The ampulla is here. So you're going down the bile duct this way. So you've got the bile duct that's dilated. It's big. It's dilated. This is the portal vein that I was talking about. I'm using some Doppler to show flow. And then this dark area here, unfortunately you can't see it that well, is tumor. And the tumor obstructing the bile duct. So the bile duct's dilated. And if you look closely, you can see here's the portal vein, and here's the interface, and the tumor is sitting just on the interface. And the fat plane's okay, but this is what I was saying. This is a resectable tumor. It's got just a touch of involvement to the portal vein, but it's not really causing any contour regularity. So this patient would go straight to a shot at a Whipple. In contradistinction, this is the same anatomy. The liver's up here, and here's the bile duct coming down to the ampulla. Here's the portal vein, and here's the mass. And the mass is blocking the bile duct, but this time the mass is clearly invading the portal vein. And this makes the patient borderline resectable. We want to give him some neoadjuvant chemotherapy and hope that when the surgeon does get in there, that this just falls off and peels off. Because if you do it, you can do a vein resection here, but if you do, the hospital stay is going to be longer, the prognosis is jeopardized. So again, EUS trying to determine if this is resectable or borderline resectable, because we believe that neoadjuvant chemotherapy has a role here. This is a case actually from Chicago. I worked with a very wonderful, very prominent pancreas surgeon, Mark Telemonte, and he found or was referred a 6-millimeter tumor in the head of the pancreas. And he was going to operate because it had to come out. It was a young guy. He's 52 years old. And he finally kind of got nervous. And he said, you know what, go in there and get me a biopsy. Let's make sure it's a pancreas cancer. So I did the EUS, and there was a 6mm tumor in the head of the pancreas. But what he had, when I looked up at the liver, this is the liver, and you can see this MET. This is a typical MET with a hyperechoic center. It's ringed by its dark area, hypoechoic. So there's a MET in the liver. And here we're biopsying it. I'm putting a needle in there. And this was biopsy-proven adenocarcinoma. And so we saved him a Whipple. He did really well with chemotherapy for a couple of years. But my buddy Mark was very grateful because he would have resected, done the Whipple, and then a month or two later it would have been stage 4 disease. So this is another patient with who was referred to me. He had some weight loss and abdominal pain. He was referred to me about 14 months ago. And he is a retired gastroenterologist. I won't mention his name, but I know there are some people in here that have worked with him. And a wonderful guy. And he, unfortunately, on CT scan, had this, which is the, here's the tail of the pancreas, well, this is body of the pancreas. Here's a mass, and it's invading the aorta. And so he said to me, he goes, look, I'm in my 80s. Why would I want to, go through an EUS? I know my time has come. And I kind of talked with him. I said, well, there's always a chance. And so what we did was we did the EUS. And the first thing that I noted is that he had, this is a liver, and I'm trying to see if I can see it, but it certainly shows up here for me. There's a liver met. Where is it? It's right here, okay? This is a liver met. So this is all liver. This is a met. And I thought I would get make sure what we had, so I put a needle in this. And I don't know if it was brandy, I can't remember, but I think it was. And she goes, well, you got lymphocytes. So I said, So we then went ahead and biopsied the primary tumor, and it was lymphoma. This is all lymphoma. So it was a large B-cell lymphoma, and diffuse large cell B-cell lymphoma. And I saw him in the office about 3 weeks ago. He has no evidence of disease, and he's writing a book. So, and he's a very prominent, very grateful, very wonderful man, and I'm very happy to have been involved in his care. I mean, it's wonderful. Anyway, let's just switch quickly over to biliary strictures. And the first concept I just want you to understand is that not all biliary strictures are cancer. There is malignancy, but there's also primary sclerosing cholangitis. There's chronic pancreatitis, which causes strictures. And then there's these autoimmune diseases that we see, autoimmune pancreatitis and autoimmune cholangiopathy. You can get ischemia, usually that's in the setting of a liver transplant or a surgical mishap at a gallbladder where the hepatic artery is injured, but that ischemia causes a fibrosis, and you get a stricture of the proximal common duct. And finally, Marizzi syndrome, which we see a lot of because we have enhanced awareness of it, where the cystic duct is inflamed during a gallbladder attack, or there's stones in the cystic duct, and they compress the bile duct and give you a stricture. So not all strictures of the biliary tree are malignant. Now, in general, it's thought that the best way to approach biliary strictures is with ERCP, which is a scope test that we do where we go in, actually into the ampulla and then up the bile duct and can brush and biopsy the lesions. But, and then actually some people are a little bit more liberal because they found that, well, EUS is a good test for that pancreatic area that I showed you on those, with the portal vein, you're sitting right on top of the head of the pancreas. But anyway, I don't believe that. And I usually quote this study. Here's a study of 24 patients. They had a biliary stricture, and they had an ERCP and no diagnosis. Now, EUS visualized a mass in 23 of the patients. In 13 of the patients of the 23, cross-sectional imaging did not even see the mass. Now, in this case, fine needle aspiration was positive in 17 of the 23, and 3 additional cases were atypical or suspicious. So from my point of view, EUS, and this is controversial, but it depends on who's doing it and what their passion is, but from my point of view, EUS is the best test for bile duct malignancy as well. This is a patient that we had here at French, and here's an obvious tumor that you see with EUS. There's nothing, a biopsy positive for cholangiocarcinoma. This is up in the liver. It's in what we call the porta hepatis, and cross-sectional imaging didn't see anything. and this happens all the time. I think most of the tumors in the high bile duct are not seen on cross-sectional imaging. Now I'm going to shift quickly over to therapeutic EUS, and we'll talk about celiac plexus neurolysis. I'll tell you what I'm not going to talk about is radiofrequency ablation of neuroendocrine tumors, but I just want to summarize it real quick. We are able to put radiofrequency probes through the needles that we use and ablate tumors. And we don't really do that very much, but last fall, there was the Advanced Therapeutic Endoscopy course in Chicago put out by the ASGE, and I actually got to demonstrate this. And the technology is such that you can accurately destroy 1 centimeter lesions. We have probes that just go 1 centimeter. And so where this comes into play is I've had a couple cases of elderly patients that can't handle a pancreatectomy, but they've got a neuroendocrine tumor which makes insulin. And they keep putting out these huge levels of insulin, and they can't walk. They just keep having hypoglycemic episodes. And you go in there, put the probe in, you find the lesion, which is difficult, but you can find them with the EUS. And you put the probe in the lesion, and you burn it, and most of them have a great response. So it's something that you can really do to help people. The other thing I'm not going to talk about is EUS-guided intratumoral chemotherapy injections. But this is coming, and I'm telling you, we're going to be there. We just haven't been able to get really good results yet, but I can access these tumors, and it doesn't take a whole lot of sense, or to know that sooner or later we're going to have these lesions that are just a little bit too advanced, locally too advanced, and we're going to inject chemotherapy, and we're going to improve the outcomes. Pancreas, esophageal, we're doing it, but we're just not getting there yet, but it will come. Okay, so celiac plexus neurolysis, and I think this is a kind of an important thing because it can make patients more comfortable that have advanced pancreatic cancer. What we do is we put a needle into the plexus of nerves that serve the afferent, or the pain-sensitive fibers of the abdomen. These are conveniently located between the celiac artery and the superior mesenteric artery. I'll show you this in a minute. And we inject bupivacaine, which just helps them feel a little bit better, but we inject absolute alcohol, and we destroy the nerves. In general, and actually here's what it looks like. We're in the stomach, and we just turn posterior. Here's the celiac artery, and here's the superior mesenteric artery, and in between you've got this plexus of nerves. And you can go in with the needle, and you can either inject in the nerves themselves or around. We're kind of debating what's the best way to go. But no matter how you do it, in a meta-analysis by a gentleman Pulley in Digestive Diseases and Sciences from 2009, there's about an 80% improvement. Now, the argument that's going on with celiac plexus neurolysis is whether we should do it when patients start to fail their narcotics or whether we should do it early. And I can tell, it's my feeling that the earlier we get to these patients, we're probably going to have a benefit. And once the pain pattern is established, it's hard to break. Here's what it looks like to us. Here's the celiac artery, here's the SMA artery, and we light them up with Doppler because you don't want to inject into an artery. One of my colleagues at the Mayo Clinic, who I know very well, Dr. Levy, who I would consider to be one of the absolute experts on this procedure, he had the unfortunate circumstance of injecting with the alcohol, but he hit a aberrant spinal artery that was coming off of the celiac, feeding the spine, and the patient became a paraplegic. So, and I'm telling you, this man is the best. So anything can happen, but generally this is a very safe procedure, and it can offer benefit to what's really a debilitating situation. The next thing I'm going to talk about, and I am getting to the end, so I promise, is EUS-guided gastrojejunostomy. And I just want to show you what that means. In pancreatic cancer of the head, the surgery is a Whipple procedure. And what we do is the surgeon removes the head of the pancreas, but he also removes part of the stomach, or may not. There's something called a pylorus preserving. But either way, he's getting rid of the duodenum, and you anastomose what's called an afferent limb to the, you get a gastrojejunostomy with an afferent limb and an efferent limb. Now, You then hook in the bile duct. This is a big surgery, and this is why we're so accurate with who needs it. The bile duct gets hooked into the afferent limb, and the pancreas gets hooked in. So unfortunately, if you have a recurrence of the pancreatic tumor, it can block this afferent limb and cause the patient misery. They get pain, distension, bloating, and they get jaundiced. So, and this is what it looks like. This is not the patient that I'm going to show you. This is another patient with afferent limb syndrome, but it shows you, here's the liver, here's the afferent limb, and it's coming up to the stomach. What we did in our patient, we started out by doing a percutaneous drainage. We had the radiologist go with a needle into the liver and then work his wire, actually it was a she, I'm sorry, work her wire into the afferent limb and drain. But the patient did not get better. She remained jaundiced and she continued to have ongoing right upper quadrant pain because she was blocked, it was an obstruction. So this is what we do as endosonographers. We thought about what we can do to circumvent the problem. There's actually were a couple of these in the literature. I read there were 2 published. What we did was we pursued a procedure where I was able to anastomose the stomach to the afferent limb, allowing the afferent limb to decompress into the stomach. Can we run the video? Okay, so this is, I'm just playing around at this point. Here's the liver. I've got the EUS. This is live EUS. I've got the liver. And then I'm going to localize the afferent limb. And you can see it's grossly distended. This is the afferent limb that drains up to the liver. And 3.5 centimeters, it's distended. And when you're sticking a needle in, you're getting a little nervous. So I want to make sure what I'm going into. So I'm sticking a needle into the limb. And I'm pulling back bile. So I want to make sure that I was in that bile obstruction. So we confirmed it was bile. Now I'm using a axial stent, and I bore in with cautery into the limb, and I'm going to activate this right here, activate this edge of the stent. It's like a yo-yo, 2 large stents. Here's the, I should say 2 large flanges. Here's the internal aspect. I mean, this is in the stomach. I've drained, the other end is in the jejunum, and here we're draining, and here comes bile coming out. And so we've decompressed this patient. Now, this is a durable anastomosis. It takes the place of a surgical gastrojejunostomy. Now, this patient felt better immediately after the procedure. She went home the next day, and and her jaundice cleared within a few days. So, you just have to keep thinking. There's just a lot of applications that EUS allows us to play with. And speaking about applications, one more. These are, I just want to talk a little bit about fiducials. These are little metal pledgets because you don't always know where you are. And so we were able to put little metal pieces through a needle to localize tumors. And here's a case, this is an interesting case. This case occurred about 6 weeks ago. A gentleman who had I think he had diverticulitis, had a CT scan, and they showed a mass in the head of the pancreas. So he's 79 years old, he's in pretty good health. And he comes into the office, and I said, well, the CT shows that you have a mass in the head of the pancreas. He goes, oh gosh, I think I had that when I was a kid. So, and they bypassed my stomach. And I knew what he had. He had what's called an annular pancreas, which is a rare condition where the pancreas congenitally wraps around the duodenum, causes obstruction, presents early on, and you bypass it and they do fine. So he did well for like 70 years. So I went in and looked at the annular pancreas. I still wanted to look because I thought maybe there is a mass in the annular pancreas. There wasn't. But what he did have was a pancreas tumor that was not visualized. Here's the pancreas tumor. This was, I thought, somewhere in the neck of the pancreas or the body. So we presented him at tumor board, and our surgeons got kind of anxious because of this. This is significant anatomy with this annular pancreas. So we decided to send him down. He went down to UCLA. See, we sent him. All right, and I'm sorry, I'm wrong. He went to UCSF. Sorry. So the first call I get from the surgeon was he says, well, I've got the CT and the MRI and there's no tumor. I go, there's tumor. So he says, well, send up the slides. So we sent him the slides, and then he believed that there was tumor because we had biopsied the lesion. And then he says, okay, Well, now I don't know what to do. I don't know whether I'm going to take out a Whipple or I'm going to do the distal pancreatectomy because I can't find the tumor. So what would you suggest? So I said, well, let's put fiducials in. So I went back again and identified the tumor, and I put these little metal pieces in, and you can see them right here. This is a CT scan, and you can see the celiac artery, but it clearly localizes exactly. Now you can't see the tumor here, but you see the metal fiducials, which identify the anatomy. Here's a little bit more magged portion. You can see the bifurcation of the celiac artery, so it shows him exactly where he needs to go. Here's the splenic artery, and this is hepatic artery. This is classic anatomy. And then here's a coronal section where you can see I actually put 4 of these in, and you can see the anatomy to the superior mesenteric artery here and the celiac artery above. And I'm not sure, he hasn't been operated on, so I'm not sure if he's going to need to do a Whipple or if he's going to do a distal pancreatectomy, but he has the information to do it. So another situation where we were able to help the surgeon to do the right thing or hopefully do the right thing for the patient. And I think that's going to be it. I'm just going to quickly summarize a couple points to remember. Remember that EUS is the way to go for early esophageal, gastric, and rectal cancer because it gets that early T staging that helps us guide therapy and for the patient. It's the most sensitive test for pancreatic cancer. It allows us to reliably provide a tissue diagnosis for pancreas and biliary cancers. And consider, if you have the patient who has pancreatic cancer, consider earlier rare than later doing a celiac ganglion neurolysis if the patient has stage 4 disease and is likely to have pancreatic cancer pain as their disease progresses. I think that's about it. So I'm grateful and thank you very much.
Thank you.